is composed of two sessions, and the two sessions for here, the first one will deal with the abdominal examination by Barium studies and the brain X-ray, and the second part will deal with the value of a CT scan in assessment of abdominal disease. Then we'll start by the evaluation of the abdomen by brain X-ray and barium studies. And as you all know that the brain X-ray of the abdomen has many advantages, since it is able to detect radiopaque calculi and to show calcium and to assess the gas pattern in the bowel, also to detect foreign bodies and intraperitoneal fluids as well as air, to see enlargement of particular organs in the abdomen, and finally to show some of the bony abnormalities in the spine as well as in the pelvis. And I will show to you some of these examples, and here is the detection of radiopaque stones. As you can see in these two different patients, this is the small left renal calculus, and this is the large one, right left renal calculus, which is known as the Staghorn stone. And in this X-ray, you can see two radiopaque calculi in the gallbladder region projected outside the renal shadow. And here you can see multiple calcific foci in the renal area, representing a case of nephrocalcinosis. And this is the calcified uterine fibroma in X-ray of the pelvis of a female patient. Then here you can see extensive calcification along the anatomic site of the pancreas in a case of chronic pancreatitis. And this is calcification of the gallbladder wall, which is known as porcelain gallbladder, and this is considered the precancerous situation. Concerning the gas shadow, you can diagnose the possibility of small and large bowel obstruction from the distribution of the gas shadow in the abdomen. And as you can see here, the jejunal lobes are distended and dilated with gases. Then in the erect film, you can see multiple air fluid levels. Then you know that this is an intestinal obstruction involving the distal part of the jejunum. And in this case, you can see multiple air fluid levels in the colon as well as in the small bowel, but you cannot see the cause of obstruction usually in the brain film. So this is a CT scan of the same case, where you can see a malignant lesion involving the rectosigmoid, the sigmoid colon, and this is the cause of these obstructive changes. Normally in the abdomen, you can see along the lateral wall of the abdomen a black line made of fat, which is known as the flank strip. And this flank strip is usually obliterated whenever there is fluid in the peritoneum, as in this case with ascites, and you cannot see the flank strip in this X-ray. Then you can also judge the enlargement of the liver and the spleen from the plain X-ray. As you can see in this particular case, there is the huge enlargement of the spleen reaching down in the pelvis in a case of splenomegaly. And also you can see foreign bodies. This is the foreign body in the region of the ileocecal junction, and this is the foreign body in the rectum, and this is the foreign body itself. And here you can see multiple radiopaque tablets in the stomach, and in this case you can see also multiple radiopaque tablets along the intestinal lobes. Then we came to the assessment of the gastrointestinal tract by barium. And barium has many advantages, like it provides a roadmap for the area to be examined later on by endoscope. It can show the site of the lesion, and it also can predict in many cases the nature of the lesion. And the endoscope, on the other hand, cannot see outside the bowel lumen. It cannot bypass the tight stricture in the bowel. In many cases, it cannot determine the length of the lesion, And there are some areas in the bowel that cannot be reached by the endoscope. And these are the barium preparations. Barium originally is a powder which can be dissolved in water and given to the patient. But nowadays we have already ready-made preparations of barium, and they are also disposable, used for only one case. Then you need not to prepare barium anymore. And this is also a contrast material which is water soluble, known as gastrografine, and it's given instead of barium in certain conditions. And these conditions include suspected bowel perforation, in order not to let barium go into the peritoneal cavity. Then in cases of suspected intestinal obstruction, and also after surgery, if you suspect an stomatic leak, you should give gastrografine instead of barium, in order not to let the barium go into the peritoneal cavity. And whenever we administer barium, we usually add some air to this barium by any means. Then it can get this appearance, which is known as the double contrast study. And here is double contrast study of the stomach. You can see nicely the mucosal folds, and you can see the gastric antrum as well as the first part of the duodenum. Then there are four main lesions that can affect the whole gastrointestinal tract. These four lesions include the filling defect, the ulcers, the diverticuli, and the strictures. Then what do you mean by a filling defect? A filling defect is an area which cannot be filled with barium due to the presence of a space-occupying lesion. And in this case of barium swallow, you cannot see barium cannot fill this particular area because there is a tumor in the esophagus preventing barium to fill this area. And in this case, we call this an intraluminal lesion. But barium cannot fill also an area of the esophagus which is compressed from outside by a space-occupying lesion or by osteophytes, as you can see in this case. And here we can call this extraluminal lesion. Then the stricture means an area of narrowing in the gut. And we have two types of strictures. This stricture, which is known as the rat tail configuration, which may indicate a benign lesion. And this is the characteristic stricture, which is known as apple core configuration. And you can see it's almost similar to the apple core, with hanging the edges above and below. And this is diagnostic of malignant stricture. Then the diverticulum is just an outpouching of the bowel which is filled with barium. This is the second part, the duodenal diverticulum, and this is the third part, the duodenal diverticulum filled with barium. The ulcer is an area of mucosal injury where barium can collect inside. And if you look to the ulcer from the front, then you can see a small collection of barium with mucosa radiating to the side of the ulcer. If you look to the ulcer from the lateral aspect, then you can see a small projection beyond the bowel contour, which is filled by barium. Then we came to the different parts of the gut and to see the lesions affecting each part. The esophagus is examined by what's known as the barium swab. We give a barium paste, which is semi-solid or semi-fluid, and we monitor the transit of barium through the esophagus under screen. And you can see the barium bolus going through the esophagus until it reaches the stomach. And this is the esophagus which is filled with barium, and this is the esophagus which is not filled with barium. This image is for configurational abnormalities, and this image is for mucosal lesions. And in the esophagus, we may have a stricture, filling defect, ulcer, and diverticulum. Strictures in the esophagus include the corrosive stricture, the peptic stricture due to reflux, the stricture due to achalasia of the cardia, and the malignant stricture. The peptic stricture is usually located in the distal part of the esophagus, and it is the result of gastroesophageal reflux, resulting in inflammatory esophagitis, then followed by fibrosis and stricture. And this is, of course, a benign lesion showing the classic rat tail configuration. The corrosive stricture is usually located high up near the level of the aortic arch, and it is a long stricture, and it has the characteristic rat tail configuration with smooth edges denoting the benign lesion, and the history of corrosive intake is usually present in such cases. Then this is a classic case of achalasia of the cardia, where you can see a smooth narrowing of the distal part of the esophagus with marked proximal dilatation. Another case of achalasia of the cardia with smooth narrowing of the distal part of the esophagus and proximal huge esophageal dilatation. Then this is the malignant stricture, which is almost similar to the apple core, and we call it apple core stricture, which indicates malignant lesion in the middle part of the esophagus. Another apple core configuration representing malignant stricture in the esophagus. The third lesion representing a malignant lesion in the middle part of the esophagus. Then filling defects in the esophagus may include benign lesion, malignant lesion, and esophageal varices. Actually, in many times, we cannot differentiate benign filling defects from malignant filling defects, and we need the help of the endoscope in order to have biopsy and confirm the diagnosis. And this is actually, from the radiological point of view, a malignant lesion producing two filling defects in the esophagus. And this is the characteristic appearance of the esophageal varices, which are the dilated veins secondary to portal hypertension in the wall of the esophagus, and you got worm-like filling defects. And this is another case with worm-like filling defects in the distal part of the esophagus representing esophageal varices. Then we came to the diverticuli. We have a diverticulum in the upper esophagus known as zenchero-diverticulum, one in the middle part of the esophagus, which is known as middle esophageal diverticulum, and another diverticulum above the diaphragm, which is known as epiphrenic diverticulum. This is an example of a small mid-esophageal diverticulum, and this is an example of the classic Zenker diverticulum located in the neck and the upper part of the cervical esophagus. And this diverticulum is usually located posterior to the normal esophageal course. Then this is a classic configuration of an epiphrenic diverticulum, and you can easily discriminate this from hiatus hernia by identifying the gastroesophageal junction below the diaphragm, and you can see the diverticulum is above the diaphragm. Then you came to the stomach, and the stomach is examined by barium meal. And the barium meal is performed by introduction of barium solution by mouth. Then we change the patient position, raising his right side once and his left side once, supine film, lateral film, in order to delineate most of the gastric portions by barium and air. And this is the normal series of barium meal. You can see the fundus filled with barium, the fundus filled with air, the pylorus is filled with barium, the pylorus is filled with air, and the examination is not finished unless you can see the duodenal cap and the duodenal loop as well. There are many ways to test for gastroesophageal reflux, but the simplest one is to put the patient on his right side and ask him to swallow anything. His saliva, a little amount of water, some amount of barium. Then during this act, you will see barium coming from the fundus of the stomach into the distal part of the esophagus, and you confirm the gastroesophageal reflux. And this is the hiatus hernia, where you can see a large part of the fundus of the stomach, as well as the gastroesophageal junction above the diaphragm. Another case of hiatus hernia, and this is the level of the diaphragm, and good part of the stomach is seen above the diaphragm. And this is also a sliding hiatus hernia. You can see part of the stomach is above the diaphragm. Then narrowing of the stomach may be due to infantile congenital hypertrophic pyloric stenosis, or due to infiltration of the gastric wall by carcinoma, which is known as Scaurus carcinoma. This is the classic appearance of infantile hypertrophic pyloric stenosis, where the muscle layer of the pyloric canal is markedly hypertrophied, encroaching on the lumen. Then by barium, you can see that the lumen is markedly narrowed, and the stomach is considerably dilated. Another case of hypertrophic pyloric stenosis, and the pyloric canal is narrowed and the stomach is dilated. And here you can see the gross specimen with marked hypertrophy of the wall of the pyloric canal. An infiltration of the stomach by a tumor will result in this appearance. The gastric wall is markedly thickened, encroaching and narrowing the gastric lumen. And here you can see this is what we call serous carcinoma of the stomach, marked reduction of the stomach caliber due to invasion of the wall by this tumor. And this is just to compare the serous carcinoma by the normal stomach. This is the normal stomach, which is distensible and filled regularly with barium. But here the stomach lumen is markedly reduced. It has a regular caliber and it cannot maintain barium content. The barium comes from the esophagus directly into the small bowel through the markedly narrowed stomach. The gastric filling defects will include benign lesions and malignant lesions. Added to them the gastric foreign bodies. And the gastric foreign bodies are known as gastric bezoars, and they differ according to the type of the foreign body. And this is the foreign body in the stomach, and you can see the appearance. Can you predict this foreign body, the nature of it? Sorry? Soup. Any other suggestions? And I heard someone say this is a mobile phone, but actually this is the foreign body. Okay, and there are two of these, one here in the fundus of the stomach and the other in the pyloric canal. And this is another example of a large amount of undigestible fibers in the stomach seen by the endoscope and seen by barium. You can see the stomach is markedly distended by this foreign body. And if you see a filling defect which is not mobile, then you know that this is a tumor. And similar to the esophagus, you need the help of the endoscope in order to differentiate benign from malignant lesions. In this case, you can see a filling defect along the greater curvature of the stomach. The irregularity of the margin of the filling defect will suspect it as a malignant lesion. Ulcers in the stomach may include benign peptic ulcerations or malignant ulcers. And the difference between both, in cases of benign lesions, you can see the mucosal folds extending up to the edge of the ulcer, while in the malignant ulcers are usually large, and the mucosal fold stops away from the ulcer edge. And this is the gross specimen where you can see the malignant ulcer. This is the ulcer, and you can see the mucosal folds are away from the ulcer edge because of the invasion of the adjacent tissue by the malignant tumor. And here are the characteristics or the criteria of a malignant ulcer in the stomach. The ulcer is usually located on the lesser curve. It is usually larger than 2 centimeters in diameter, and the mucosa stops away from its edge. Then the most common lesion affecting the duodenal cap is ulcers. And the acute ulcer is just an area which is filled by barium, showing persistent appearance, and you can see the mucosal folds reaching the edge of the ulcer. In the chronic duodenal ulcer, the duodenal cap will be fibrosed and cicatralized. Then you can see this characteristic configuration, which is similar to is known as in the radiology as the trifoil appearance, similar to this leaf. Another case of chronic duodenal ulceration with cicatrization of the duodenal cap compared to the normal duodenal cap in this example. And duodenal diverticuli usually affect the second part of the duodenum and may be close to the region of the ampulla of water. Then they will disturb the biliary drainage and may result in obstructive jaundice. And you remember this case of duodenal diverticulum affecting the second part of the duodenum. Then we came to the examination of the small bowel, which is performed by this meal follow-through examination. You give the patient about 300 milliliters of barium solution And you radiograph the abdomen every half an hour in order to see the flow of barium through the bowel. The examination should not be ended until you see the terminal ileum and the ascending colon. Then this is the series of the barium meal follow through. The first film will show the stomach and the duodenum. The second one will show the proximal jejunum. The third one will show the rest of the jejunal loops and maybe the proximal ileum. The fourth one will show most of the ileal loops, and the colon is also identified. Then one of the common lesions affecting the small bowel is Crohn's disease, which will result in filling defects, ulcerations, and restrictions. And this is the classic appearance of Crohn's disease affecting the terminal ileum. This is the normal terminal ileum, and this is the terminal ileum which is markedly narrowed due to affection by Crohn's disease. And this is a typical appearance of Crohn's disease affecting the terminal ileum. You can see the terminal ileal loop is markedly reduced in caliber with irregular serrated outline due to fine ulcerations. Also, Crohn's disease can produce multiple filling defects in the terminal ileum, which is known as the copelestone appearance. These filling defects represent the hypertrophied normal mucosa between the ulcerated mucosa. Then Crohn's disease also may produce multiple strictures in the bowel, and this is an example. Stricture here, normal segment, and the stricture there. This appearance is known as the skip lesions, which are also characteristic of Crohn's disease. Diverticuli in the small bowel are commonly seen in the duodenum, but may be seen in the small bowel, as you can see here, multiple diverticular outpouching in the jejunum. Then we came to the barium enema. We introduced barium per rectum until we fill the whole colon. And we also introduced some air in order to have this beautiful film, which is known as double contrast barium enema. And you can see the rest of the whole colonic segments. This is also another example of double contrast barium enema showing normal configuration of the colon. The colonic lesions include filling defects, ulceration, diverticuli, and restrictions. And the diverticuli in the colon are very famous. And this is the diverticular disease of the colon. You can see multiple diverticular outpouching coming from the transverse colon and also in the region of the sigmoid. Diverticular disease of the colon is common in the distal colon, in the descending colon, and the sigmoid colon, as you can see in this case, but can affect most of the colonic segments. One of the complications of diverticular disease is to rupture and to form a varicolic abscess. And in some cases, this varicolic abscess may communicate with the bladder lumen, resulting in a fistula, and then you can detect air inside the urinary bladder. Ulcers in the colon are usually secondary to ulcerative colitis, but may be also due to Crohn's disease. And this is the appearance of ulcerative colitis. This is the appearance of the normal colon. The colon is distensible, and you can see the hostrations of the colon normally. But in cases of ulcerative colitis, the caliber will be reduced and the colon will be effaced. There is no hostra in this colon. And this is another example of ulcerative colitis. You can see marked reduction of colonic caliber as well as total effacement of the hostral pattern. In early stages of ulcerative colitis, if you have the double contrast study, you may be able to see the ulcerations. And these ulcers are in the wall of the colon filled with barium, giving what's known as the granular appearance of the colon, which is classic for early stages of ulcerative colitis. And this is the normal colon, and this is the colon which is affected by ulcerative colitis, and you can see the caliber reduction and the effacement of the hostral pattern. One of the major complications of ulcerative colitis is the development of malignancy in this colon. And you can see this colon is affected by ulcerative colitis, reduction of the caliber, effacement of the hostral pattern. Then in the ascending colon, you see the classic apple core configuration, which represents a malignant structure on top of ulcerative colitis. Then polyps in the colon or filling defects in the colon are usually the result of polyps. Polyps may be benign or malignant. And in the children, you may have a filling defect which is secondary to intussusception. The polyp is considered benign whenever it has a pedicle, and the sessile polyps are usually of malignant nature. And this is an example of barium enema showing benign polyps. You can see the pedicle of the polyp, and these are benign polyps in the colon. This is an example of a malignant polyp in the sigmoid colon. It is a sessile without pedicle. And this is a known case of familial bulbosis, where you can see numerous polypi all through the colon, and you all know that this is 100% has a 100% malignant risk. Then this is the intussusception. Whenever you introduce barium, it will stop at the site of the intussusception. Then you can see a filling defect, but this is an easy diagnosis whenever you know that this is a child, and intussusception may be also seen in adults, and it can be beautifully demonstrated by ultrasound and CT whenever you can see this whirly configuration of a loop inside the another loop. And this is the gross specimen or the operative appearance of the intussusception. Then we came to the strictures in the colon, and the strictures of the colon are mostly malignant. Benign strictures in the colon are rare, and in the children we may have a stricture which is due to Hirschsprung disease. This stricture has the characteristic apple core configuration representing malignant lesion in the recto-sigmoid junction, and this is another apple core configuration in the sigmoid colon representing malignant stricture, and this is a third malignant stricture in the transverse colon showing the apple core configuration. And here also you can see the apple core configuration in the descending colon representing a malignant stricture. In this child, you can see distension of the bowel by gases, suspecting a cause of obstruction. Then whenever you are suspecting Hirschsprung disease, we should inject barium carefully, aiming at delineation of the site of narrowing only. And we do not usually fill the whole colon with barium. Then we inject barium until we reach the site of narrowing, and we delineate the segment, the whole segment of narrowing. Then we'll stop the examination after that. And you know this Hirschsprung disease is due to the presence of a ganglionic segment in the colon, which will not distend, and it represents an obstacle to the proximal colon. Then you got considerable dilatation of the colon proximal to the site of obstruction. And I thank you very much.